Hi everyone, welcome to this Make a Medic tutorial. Today's topic is the treatment of Parkinson's disease. So when it comes to Parkinson's medications, all of them are trying to achieve one main aim, which is to increase the amount of dopamine in the substantia nigra. And there are two main classes of medications which are used in the first instance to try and achieve this aim. So one of them is the combination of L-DOPA, which is a precursor for dopamine, and a peripheral dopa decarboxylase inhibitor. I'll explain what that means in just a second. And the other class are dopamine agonists. So these are medications that can mimic the action of dopamine, but is also able to cross the blood-brain barrier and get to the site where it is needed. So here we have a diagram of the brain and the circulation. So the capillaries within the brain have a special type of endothelium with very tight junctions that prevents various substances from entering the brain. So essentially the brain is a compartment which is tightly regulated in terms of what can come in and go out of it. So within the brain we have the substantia nigra of the basal ganglia, and within the substantia nigra we have dopaminergic neurons. Inside these neurons, there's an enzyme called dopa decarboxylase, which is responsible for converting L-DOPA into dopamine. So these are the neurons which are struggling to produce enough dopamine in Parkinson's disease. So this is the site at which we want to get dopamine being produced. So one important fact to bear in mind is that there's a peripheral form of dopa decarboxylase which can again convert L-DOPA into dopamine, but this exists outside the brain, and this can cause quite a lot of problems. And another important structure to be aware of is the chemoreceptor trigger zone within the medulla, and this is the part of the brain which responds to various hormones and toxins and can trigger nausea and vomiting. So it's slightly different from the rest of the brain because the blood-brain barrier in that area is slightly disrupted, meaning that more hormones and chemicals can access this area. So hypothetically, if we were to just give L-DOPA on its own, the issue is that it'll enter the bloodstream and it'll be converted by peripheral dopa decarboxylase into dopamine. One of the main issues with this is that dopamine can't cross the blood-brain barrier, and hence it won't actually get to the substantia nigra to give any sort of therapeutic effect. In addition to that, dopamine can get into the chemoreceptor trigger zone and trigger nausea. So that's why we need to administer L-DOPA with a peripheral dopa decarboxylase inhibitor. So the peripheral dopa decarboxylase inhibitor will, as the name suggests, inhibit that enzyme in the peripheries. So this allows L-DOPA to persist within the circulation. Some of it will still cross into the chemoreceptor trigger zone, and nausea is a fairly common complication of these medications. But the benefit is that the L-DOPA can get into the brain, into these dopaminergic neurons, and by the action of that central dopa decarboxylase, it can lead to the production of more dopamine within the substantia nigra, and that's how it brings about the therapeutic effect. Examples of this combination of medications include cobeneldopa and cocareldopa, and these are often the medications that are started as a first line in patients with Parkinson's disease. Examples of dopamine agonists, on the other hand, include ropinirole, pramipexole, and apomorphine. So these, as I mentioned earlier, are medications that can mimic the action of dopamine, but are able to traverse the blood-brain barrier and get to the substantia nigra.